Welcome back to the Physical Therapy San Pedro podcast. We are in episode 41 and we're talking about lateral hip pain. I am your host, Dr. Janae Brown, and I am joined by two of the best physical therapists in the business who happen to be physical therapists at Physical Therapy San Pedro. To my left is
Dr. Bay.
And to my right is
Dr. Yana.
Dr. Yana, Dr. Bay. Here we are in episode 41. Super exciting. We're in the end of the second month of the year, and we're going. We are in our hip series. Dr. Yana wrote this incredibly wonderful first blog of hers. So let's give her some kudos there. She did a really great writing it, and it's a really great blog. So Dr. Yana, you wanted to write about lateral hip pain. Tell us why you chose that.
Yes. Okay. So lateral hip pain, it's something that we see here pretty often, especially among active individuals and the athletes that we work with. In addition to that, as Queen Shakira says, hips don't lie. So with that being said, we use our hips for everything. They support our body weight. They have so many different planes of motion. So I just thought it would be a great topic to cover because of how prevalent it is.
Yeah, it is prevalent. We see it a lot. It's I don't want to say a great injury, but it's a fixable injury. I feel like it's one of them ones that we have high success with our patients.
Definitely.
So that's what we love when we can actually help people, right?
Yes.
It's the best. So let's go over some specifics. So we're joined here by LeBone James, and we gave Dr. Bay anatomy today, so she was happy.
Love it.
So she's going to talk to us about the lateral hip and the really cool things about the lateral hip.
Yes, definitely. As Dr. Yana said, the hip joint is a very complex structure, which allows for multiple planes of movement. It's great because it's a weight-bearing joint. So the actual shape of our hip joint, to review, is a ball and socket joint. So that socket with the ball inside allows for the hip to move in every direction possible. Bony-wise, the big bones that we're going to be discussing today are the ilium, which is one of the bones of the pelvis, the femur bone, our thigh bone, and a very important prominence on the femur called the greater trochanter, and that's a point where a lot of tendons insert from very important lateral hip muscles. So let's jump to the muscles we're going to be talking about today. So on the side of the ilium, more shallow or superficially would be our gluteus medius, and a little bit deeper to that, our gluteus minimus. And more to the front, but still laterally on the hip, is TFL, tensor fascia lata. A big one a lot of our patients come in asking about is a tendon called the IT band. This starts in the tissue of the TFL and it runs down the side of the leg and out to the lateral knee. It is connective tissue. It's not a muscle. Tendons of the glute all connect in on that greater trochanter, I said. There's some important ligaments, and then also back to our greater trochanter is the bursa that lives there. It's called the trochanteric bursa, and that's a fat pad or a fluid-filled sac, and tendons run right over it. So in some of the syndromes we'll be discussing later, that's a common irritated area. Yes, we did it.
You did it.
Oh no, I lost him. Thank you, Laboni.
I forgot how much Dr.
Such a good educator.
I forgot how much you love the hip, but I was like mesmerized right now as you were giving us all those descriptors.
I really like the hip.
And you did your, long hand movements. That was fantastic.
It's like
she
choreography.
Loves the hip.
Shakira would be proud.
She would be so proud. Yeah. Okay. So Dr. Yana, talk to us about some of the pathologies that we see in the lateral hip and maybe some risk factors that might put our audience at risk and maybe help them identify maybe the differences between one lateral hip pathology versus the other.
All right. Will do. Okay, starting with greater trochanteric pain syndrome, or GTPS. That's usually classified as pain that's like pain and tenderness at that lateral hip where that trochanteric, that greater troch is, as Dr. Bay showed us. It's usually caused by repetitive activities like walking, running, or constantly laying down on that greater choke. And then next we have ITBS, or iliotibial band syndrome. It's also classified as snapping hip. And that one involves irritation of that IT band and inflammation as well. And then it presents as like tenderness and radiating pain that can go all the way down to the side of the knee as well. And then we have trochanteric bursitis. So as previously mentioned, that bursa, that is like the fluid-filled sac that sits by that greater troch. It can become inflamed if the tissues around it are either like too tight or, you know.
Frictioning on it.
Yes, thank you.
Yeah.
Friction. Mm-hmm.
And with that, that it'll also be localized pain at times, but it could also radiate into the thigh. And then we have gluteal tendinopathy. That's usually caused by weakness of the glute muscles. It could be the glute med, the glute min, or the glute max. And that's also caused by, it seems to be a theme, repetitive activities or overuse, and weakness, of course, and biomechanical issues. So like muscular imbalances. And then last but not least, we have TFL, tendinopathy. So that's that muscle that sits a little like anterolateral, partly in the front, partly on the side. And that's used for motions like abduction and internal rotation. And if that gets irritated, also due to repetitive activities like running or cycling, that can also cause pain in the lateral hip, and usually caused by like muscle imbalance as well, and biomechanical factors.
Okay. That's great. Thank you for the details on those 5 conditions. So I'm going to talk a little bit about treatment, and I'm going to be very general in terms of treatment because there's so many specific things that we can get into, and we're going to talk to you guys a little bit about how we might treat one condition versus the other, or what might stand out to us when a patient presents to us with certain complaints where we might kind of take ourselves in terms of direction and clinical testing and things like that. But generally speaking, when someone has pain in the lateral hip and they come to us, we're going to try to find out why they're having the pain, what activities first that they're doing that might be creating pain in their hips. So maybe they're running, and when they run on 5 miles or something like that, they have pain. But maybe when they run, less than that, they don't have pain. So we might try to break apart some of the activities that they're doing and figure out, can we modify the activity? Can you still run? And maybe we just change that a little bit. Or maybe they can't run at all. And then what can we do instead of running? Can we walk? Or is it so severe that we can't even walk? We got to kind of figure out what you do in your daily life and what is difficult for you, and then modify that activity versus you just stopping altogether and not doing anything, because that's not helpful either. So we want to keep doing the things that feel good. If running feels great, but squatting hurts, we stop. If squatting hurts, but running feels great, we run. We want to keep doing the things that the body likes, because that actually helps the body heal. But we want to avoid the things that are really irritating your lateral hip. And so that's kind of what the activity modification piece is. And so we basically will look at each person a little bit differently. That's why it's kind of an isolated situation from person to person. Next, we're going to look at your movement mechanics. How do you walk? How do you run? How do you squat? Whatever things that you have to do. If you play soccer, how are you approaching the ball? How do you shoot the ball? Like, we're going to look at anything that you're doing that is painful and watch how you're moving through that thing. A lot of times there's just some simple corrections that need to happen in your movement that can help actually reduce your pain or change sort of your function. So we're going to take a look at all the things that you do on a daily basis. Everybody's a little different, and break those things down and watch your movement and try to help you move a little bit better while you're in pain, to reduce the pain. And then really just long term, making sure that maybe you just have really weak external rotators, or maybe your right external rotators are weaker than your left. There might be some reason for that. We want to figure out why, but we also want to guide you and get you moving better long term. We're going to use our hands. We love our hands. We like to use our hands for manual therapy. Some of us like to use other things for manual therapy, like cupping. And basically, our manual therapy is a tool for us to be able to help your soft tissue move, help your joints move, get things feeling a little bit better in terms of pain and also just reducing inflammation between the layers of the skin and the muscles and things like that. So we use our hands, we use cupping, we use
Mob belts.
Mob belts. We
It's my
use,
fave for the hips.
we do, some of us use, I don't know, other than cupping. That's me, cupping, manual therapy, soft tissue work, joint mobilization. But that's pretty much, we use those things. We're going to facilitate basically the movement of your tissue in addition to doing some of the exercise-based things. So manual therapy, for some it's a lost art. Some don't do it anymore. Some don't do it well. Some don't believe in it. Here at PTSP, we all do some manual therapy, and it's not our only and main focus, but we use it to support our treatment protocols.
At the right times, it can improve someone's ability to get that deep squat, right?
Yeah.
It can improve the ability of your muscles to contract properly or coordinate properly.
Yeah.
It's all about creating that environment for healing and success.
Yeah, absolutely. Yep. And then, of course, the big stuff that we love, strengthening exercises. So we're going to start proximally at the hip and make sure that you're strong in your core and in your all the muscles that are really around the hip, get you really stable. And so we use isometrics for that. We use short lever exercises for that. And then eventually we want to get everything in the lower chain strong and the trunk coordinating with that. So those are our lunges and our squats and our RDLs, step ups, step downs. Yeah. Anything that relates to big strength. And we want to get you as strong as possible so you are supported in your hip. And then we're going to go into mobility and stretching, making sure you have good flexibility in your muscles that surround your hip. So those are your hamstrings and your quads, your IT band, your deep gluteal muscles, your big glutes, making sure everything, your hip flexors, everything is sort of flexible and has the right length on it, and there's good muscle balance. So we talked to Dr. Yana mentioned muscle imbalance a lot. We want to make sure those muscles are balanced well, and that happens through stretching, through strengthening, and then making sure we have good mobility in the bones in the hip, and that ball and socket joint can make it sometimes difficult to have good mobility based on if there's some stiffness there, or there's some stiffness that's been created from a lack of use or lack of movement in the hip. So we're going to try to help you improve that as well. And lastly, the last thing we really work on is if you play a sport, you play soccer, you play basketball, you run, we want to make sure that you feel really good getting back to that sport. So we are going to, recreate situations that you're going to have to be able to move well in. And make sure you feel good with those things. So that's, footwork, jumps, hops, transitions, deceleration, landings, all those things. We're going to make sure you feel reaction time, all those things that you feel, good getting back to. So that is big treatment. I feel like I was talking for a long time.
It was good.
It was good.
You got it all.
Thanks. Always need the confirmation, right? Okay. So ladies, let's talk about some different patients that we might have that have some of these pathologies. And maybe we can go into some specifics on someone comes to you and they have this particular sort of complaint. Where might you go and go, this is going to be probably this or this. So let's first start with, do you guys have any patients that have any lateral hip pathology right now?
I did very recently.
Okay.
He's a high school track runner.
Mm-hmm.
And his main complaint was pain in the lateral, but also the anterior hip.
Mm-hmm.
And immediately I just thought TFL. And so the first thing I did with him was...
Why did you think it was TFL?
Based on past experiences,
mm-hmm.
as well as where it was located.
So just the location of the problem, but nothing in terms of complaint wise made you go towards that.
Right. Initially.
Yes. Okay. All right.
Mm-hmm. And then with him, so I analyzed his gait and his running mechanics first.
Mm-hmm.
And then I also looked at his alignment, his leg. I noticed he had a leg length discrepancy. Mm-hmm. So I have this go-to technique. I call it a hip reset to see if that would help him. And luckily it did. So that's basically a series of hip isometric exercises that target glute max, hip adductors, hip abductors. Those are the main ones. And then after that sequence, he actually had a little bit of decreased pain, and his running mechanics also improved. So that's just one example, though.
Yeah.
Yeah.
With the hip reset, a lot of
Mhm.
people think that those things are like don't work. I don't know. Or that they're like some false idea of how to get, hips realigned or whatever it is.
Mhm.
There's a lot of controversy about it right now in our practice. Does it stop there? Like you do?
Oh,
Like,
no.
okay.
It definitely doesn't stop there. It was just like a first clue for me regarding muscle imbalance that he had.
Yeah. And then
Yeah.
what did you do beyond that? Like in terms of treating that muscle imbalance, did you continue targeting those muscles that were kind of out of like maybe one was weaker than the other or?
Yes.
Yeah. Okay.
Yeah. So
Yeah.
then his home program consisted of the ones that were weaker
Mm-hmm.
and overly tight.
Mm-hmm. Guess you have to see Dr. Yana to get her hip reset sauce.
I'll be here.
She's not telling, obviously. So you'd have to come see her directly.
Exactly. That's a little technique I have.
What about you, Dr. Bay? Do you have any current patients that have lateral hip pain?
Yeah, I've been working with one of my patients that's last month we talked about anterior hip pain. So the initial thing was she had a labral tear that was repaired via surgery. And as we progress back into her different activities, which are rock climbing, acrobatic yoga, surfing, they all require really deep ranges of motion. So she was having more of like a pinching sensation in her lateral hip. And we kind of narrowed it down to both a flexibility, joint mobility issue, and then a lack of strength at end range issue.
Mm-hmm.
So I've been targeting specifically like the length of her adductors, hip kind of like inferior medial glides, and really strengthening her glute med at end range. And now she can start to move into her lateral lunges or squats with less and less pinching.
Do you think her lateral hip pain came from the labral repair? Like, or was it?
Yeah, as we dive deeper into her history, she's like, yeah, these are movements I didn't have great access to for a long time. And as we discuss all these things, I always tell my patients, like, we all get injured for the same reasons, but they present differently.
Yeah, it's true. Yeah.
So, hers ended up in maybe her hips weren't flexible, but her activities are so dynamic. Eventually, she pushed and overused her joint into a tear, because I don't believe it was traumatic. She wasn't initially my patient. I think it was more of a gradual tear.
Okay. Interesting.
Yeah. But now we're getting her that range. So it's been fun.
Awesome. Okay. So let's say a patient presents to the clinic and their primary complaint is pain when they lay on their hip. Say it's their right hip. When I lay on my right hip, it hurts so much. Of these 5, where might you go to first? Where would you go? It might be this or this. Is there one that you would go to first?
Well, I have to study, because you mentioned that when you talked.
I did.
The first,
where
can I
would you
answer
go?
this?
Yeah, go ahead. Anybody.
The first couple that come to mind are either trochanteric bursitis
me too. Yeah.
or GTPS, greater troch pain syndrome.
Yes.
Yeah, those would be my.
Because it's more localized.
Yeah. Yeah. I feel like when someone's that irritable, when they have pain on that side, we're looking at bursa or like bony, right? Like bony, like if someone has, so I would go there too. Yeah. What would make you?
But in general, just most people with the weak glute med and glute min can't last that long either.
Yeah.
Yeah. Because the structures aren't supporting it.
Yeah. It all leads to the same things.
Okay. What if someone said they had pain with running? So I have pain with, where would you go next? They're like, I don't have pain laying on my side, but when I run, I have pain in my lateral hip. Where would you like first go to?
I would go more to the muscle at that point.
Yeah.
That's more complex. But yes, muscular.
So with
or
TFL,
IT
band
is pretty common with long distance runners.
Or just glute med weakness.
Glute med weakness.
Yeah.
Okay.
Something that's going to be brought on with higher forces and require more endurance.
Yeah. Okay. What would make you think they had like a glute med tendinopathy versus maybe a glute med. This is hard, but a glute med.
Great.
Maybe more of a glute
Make it
med
even
strain,
harder. Come on.
like a muscle strain. So that, like a strain in their glute med versus like a tendinopathy.
Oh,
Well,
history.
Yeah.
Is it acute
MOI
or is it chronic?
versus, gradual onset.
Mhm.
So what would be the tendinopathy? Would it be gradual onset or
Yeah.
okay? And then the
Which
muscle
unfortunately most people are like, I just woke up one day with this.
They think
Mhm.
it's acute. Yeah.
strain? Mhm.
But I'm like, no, you didn't.
So trauma might make it more of a strain.
Yeah.
Like I did this
A
at the game on this
fall.
day.
Yeah.
Mhm. Yeah.
A feeling of something when you change directions or
Yeah.
stepping off that step really hard and weird, a bad jump landing.
Mhm.
And then which of these would make you more than other be more overuse? Like if you were to say, because to me, like a bursitis and maybe GTPS wouldn't be overuse as much as maybe a tendinopathy, right? Or what about for you guys? What would make you, so someone said like, I increased my activities. I've been practicing every single day for the last week. And I only practice twice a week. And I've been doing that for the last 2 or 3 weeks. And they're maybe like a hockey player.
Yeah, definitely a tendinopathy because we're considering the volume and the load, and those have increased in your scenario.
Yeah. Yeah, for sure. What do you think of these 5 as the hardest to fix?
Oh.
What has been for you guys the hardest to like get rid of? Or for me, I think it's probably like IT band syndrome. I feel like IT band's tricky because it's the knee and the hip, and then
Agreed.
I feel like IT band syndrome has a lot to do with the biomechanical factors, like because it's a lot of times it has to do with people who have anatomically internally rotated hips, and so and it develops over time, and then it pulls on the knee, it pulls on the patella. A lot of times, a tissue on the lateral side. It's just it can be icky. Yeah. What about you guys? Feel the same way? Anybody else?
I would agree.
Sure.
Mm-hmm.
Yeah, you agree?
Yeah.
I don't know. They're all the same to me.
Okay.
I don't approach anything by diagnosis. I
Okay.
approach everyone by impairments.
That's true.
I don't really care what your diagnosis is.
I'm
Sorry.
I'm in agreement with that. That's why you
That's
and
a good
I.
point.
That's why you and I see the world the same.
I
But
just am
agree.
like,
I
how
agree.
can I help you? What
How
can
can-
I
what
make
can I do?
stronger?
Mhm.
What imbalances can I correct? Can I
Yeah.
show you how to move better?
Love it.
Yeah.
That's
And what
all
are
I
their
care
goals?
about. Yeah.
Yeah.
Yeah. I don't care what it is.
Should we-
Sometimes, but it's rare.
Yeah. Is there any other sauce you guys feel like we have here at PTSP? Dr. Bay wants to change my word. She doesn't want it to be sauce. She wants some other word that's not sauce. So we haven't.
Comment if you have a better
Comment
word.
if comment if you have a better word than sauce. This sauce is my word. So
She likes it.
I like
if you
it.
like it, let us know.
If you like it,
It's we'll continue.
What do the
Yeah.
kids say these days?
yeah. What do they say? See, yeah, I don't know.
What's cool?
Yeah, I don't know. But do you guys think that there's anything that we do here that might be a little different from what other clinics do in terms of approaching patients with lateral hip pain, or just in general, that might be valuable for our listeners to know? Thoughts?
Well, as always, I like to use the Pilates reformer. I really find that, especially in lateral hip pain, it gives access to those lateral hip muscles in a pain-free way.
Mm.
And not just the lying down stuff. I know that's what you're thinking about. Okay. But the legs and straps provide a lot of moments for mobility. I can usually introduce people to standing work. Like if you know the exercises like the scooter or the skater or lunges, usually people can do those pain-free on the reformer before they can do it pain-free on real land.
Yeah.
And that's because the reformer is giving us stability feedback, and it's also giving a little bit of assistance.
Yeah.
Some of those things also like feel better TRX, right? Because you have a little bit of support, and again, it's giving that stability option.
Yeah.
I was going to add, I think progressive loading when it comes to hips is super important.
Yeah, that's that in-between moment.
Yeah. Awesome. I think for me, I love the Pilates reformer too. So Dr. Bay and I have that in common, although we have different exercises that we like to utilize. But also, for me, it's return to sport training. I think that that's what makes us a little different, is that place between whatever you are doing, just not stopping at pain, but continuing on to performance, right?
Breaking down all those sport-like movements
yeah.
and making sure they're all done properly
Yeah.
and
Yeah.
with the correct muscles.
Yep. And I think that's what makes us a little different too, is we really like to focus on that and make sure that people are performing well before they go back. So, yeah. So if you have hip pain, lateral hip pain in particular, and your hips are lying to you, or they don't lie to you, or whatever is happening with your hips,
there it is.
and you need some help, we see people in the clinic here in the Los Angeles area in San Pedro. We also see patients via telehealth. So reach out to us. You can send us a DM. You could get to us on our website at physicaltherapysanpedro.com. You can contact us on Instagram or Facebook at Physical Therapy San Pedro. We have this blog is on our website where you can read full in detail what we kind of talked about today. We also have this up on our YouTube page, and we have our podcast on Apple, Spotify, Amazon Music, anywhere that you like to listen. So go tune in. If you have particular topics you are interested in learning about, let us know. We're going to move on from our hip series to our knees. No, we did knee.
I don't know.
What do we do?
Tell us.
We're going
next.
We're going up. We're going up. So we're going to go somewhere next. I can't tell you yet. Maybe it's back. So we're going up, but tune in, and thank you for tuning in. Thank you for following. We will see you guys next time.
Bye.